refuses to carry a pregnancy to term. These women again need IVF, however, they would then need surrogacy instead of a normal IVF process. Soon is when a lady is more than 35 years. I do not think it is wise to wait too long before we guide them to the right direction. The other is received unsuccessful treatment for more than 3 years. There are patients who have endometriosis, polycystic ovaries, for whom IVF is not the right option. For them, most of these couples should get pregnant within 3 years of treatment. And if for some reason they are not getting pregnant despite repeated IUI, we need to think where this patient should be heading. This is another important slide which all of us need to keep in mind, that as the age of the woman is increasing, between 30 to 35 with a good ovarian reserve is the best IVF pregnancy rates, also naturally and also with IUI. However, once you have crossed 35, 38 or 40, the pregnancy rates go down almost by 10 to 15% per year. So it is very important to refer at the right time. The problems faced are many, however, I will not highlight this slide. This is basically what we are facing in lack of standardization of many of the centers, which with the ICMR, which is the Indian Council of Medical Research, coming in a big way to legislate certain rules and regulation and to bring in a regulatory body to monitor all IVF units. There is a difference between how IVF is practiced in the West and in our country. I was working in UK for about 3 years as an IVF consultant, and now for about 3+ years here. So there are differences that I can perceive. Some things are very good here. One is the access to treatment is excellent. The costs offered are good and affordable for many people. However, in the West, these are at least 5 times to sometimes 10 times more expensive. The advantages is that it is much more streamlined there. If there is a good referral system already in place, standardized and good labs present. Now I will just briefly go through what we do in an IVF cycle, which will take about 5 minutes. In an IVF cycle, the most important thing is, after identifying the patient, is to see that we are not missing anything in this couple that will reduce their pregnancy rates. For example, in this slide, the first slide on the right, you can see an endometrial polyp. If we put the embryos back into this uterus, she will not get pregnant. So it is important to remove this polyp before we try the IVF cycle. Second is an endometrioma. If the ovary is already having ovarian cysts, it is always better to remove cysts more than 5 centimeters before offering IVF. Similarly, with large fibroids or small fibroids that are coming into the endometrial cavity. So assessment is very important. In male factor, again, whether we need to do simple in vitro fertilization or try intracytoplasmic sperm injection. Infectious disease screening, HIV, hepatitis B, VDRL screening needs to be done. Need a pointer. In IVF, what we need to explain to the couple is not all couples who undergo the treatment will become pregnant in the first cycle itself. So if we look at this slide, which says that suppose there are 100 patients who started the treatment cycle, not all would end up with egg collection. Not all would have embryos suitable for transfer, not all would get pregnant, and not all would carry a baby to term. If this is explained to the couple that there is about a 30 to 40% positive pregnancy rate per cycle and about a 20 to 25% take-home baby rate, and explain to them why this decline happens. It is not because we don't want them to get pregnant the first time, but this is what it is about. We don't know why some embryos would definitely divide inside to have a baby and some would not. However, certain factors can be treated beforehand, like I already explained. This is a cycle guide. Looks very busy slide, but basically, just to be brief, the IVF cycle starts on day 1 of the period when you start off with the injection. Then egg retrieval about on the 13th to the 15th day. and 2 weeks later is when we do the beta HCG to find out whether the lady has got pregnant or not. These are protocols with which we follow how to monitor the patient. This is how an ovary looks like when it has been stimulated with drugs. I want the lights to be dimmed, please. This is the egg retrieval process going on. This is a hyperstimulated ovary in which the needle goes in to aspirate the fluid, and then the ovary looks like this. Once all the fluid is collected, then the fluid goes to the lab for examination to look for the eggs. Once the egg collection is done, this is how the egg looks like under the microscope. The sperms and the eggs are mixed in these dishes and put into the incubator. The media we use, the incubators, the instruments that we use to fertilize the egg may have some outcome on the result. However, clean, standard, routine IVF practice should help us in giving wonderful embryos. Our previous speaker just elucidated how the embryos look like. This is a day 2 embryo with 4 cells, and this is how the embryos look as the days go on inside the lab. Embryo transfer is one of the most crucial steps of an IVF process. You have stimulated the eggs, the lady collected the eggs, formed the embryos, and now the embryo needs to go in exactly at the right place to give the lady the best chance to get pregnant. This is how the embryos are loaded. This is an air bubble, this is media, these are the embryos, another air bubble and media. These air bubbles are added so that we can see the embryos under ultrasound vision while we transfer the embryos. After the embryo transfer, 2 weeks later is the positive pregnancy test which we are all looking for, and then 2 weeks later we do the ultrasound to see if there is a heartbeat in the baby. There are other IVF techniques which I shall briefly elucidate. For example, cryopreservation, freezing the sperm, freezing embryos and freezing eggs. One which all of us should keep in mind is for cancer patients, malignancy patients, young men who are undergoing radiation or chemotherapy. This should always be offered to them so that they can freeze their sperm in order to preserve fertility for later use. Similarly, we can offer this to a lady undergoing radiation or chemotherapy. If she wants to undergo an IVF cycle prior, freeze the embryo so that her fertility status remains intact. Dr. Subramaniam has elucidated on the methods of removing sperm from obstructive azoospermia. We also have donor sperm, egg and embryo program for patients in whom there is either non-obstructive azoospermia, premature ovarian failure, or in which there is irreversible endometrial damage. These 3 slides I will brush through, but they are important. This is to show that how we need to legislate and bring into regulation IVF practice in our country so that it can be regulated and we can give a wholesome, transparent look to our patient as to how many cycles we start, how many are getting pregnant. This is a very new situation that our country is facing. We are becoming better and better with IVF. We are quite cheap, so the world is getting attracted towards us, and the ICMR guidelines have also been very open. They are allowing treatment in same-sex couples. They are allowing treatment for single parents, and of course surrogacy is allowed by the ICMR.